In March 2025, the College of American Pathologists, CAP, released updated guidelines for human papillomavirus, HPV, testing in head and neck carcinomas. Compared to the 2018 edition, the new guidelines introduce several significant changes. In this discussion, we'll review these updates, starting with some background information. Since the 1980s, there has been a steady rise in HPV-associated head and neck squamous cell carcinoma, HNSCC, accompanied by a decline in HPV-negative HNSCC. Extensive research has established that HPV-associated oropharyngeal squamous cell carcinoma represents a distinct tumor entity, with clinical and pathological features that differ markedly from traditional HPV-negative squamous cell carcinoma. Compared to HPV-negative tumors, HPV-positive carcinomas are more frequently seen in younger patients and those with higher socioeconomic status. Clinically, HPV-associated squamous cell carcinomas tend to respond better to chemoradiation and are associated with a significantly improved prognosis. Several studies have suggested that these patients may benefit from treatment with reduced-dose radiation therapy. Pathologically, HPV-associated tumors often exhibit basaloid features with a high nuclear-to-cytoplasmic ratio, distinguishing them from HPV-negative counterparts. Moreover, these carcinomas frequently present as cervical lymph node metastases. Interestingly, while HPV-associated tumors often appear morphologically high-grade and clinically high-stage, they carry a more favorable prognosis than HPV-negative tumors. There are two main types of HPV testing: P16 immunohistochemistry (IHC) and HPV-specific tests, such as HPV RNA in situ hybridization (ISH) and HPV DNA polymerase chain reaction (PCR). In the context of oropharyngeal squamous cell carcinoma, P16-IHC serves as a reliable surrogate marker for HPV infection, demonstrating both sensitivity and specificity greater than 99%. However, outside the oropharyngeal region, P16-IHC lacks specificity and cannot be used alone to determine HPV status. In such cases, positive P16 staining does not confirm HPV-driven disease, and HPV-specific test is needed to confirm HPV status. With the background established, we can now turn to the 2025 version of HPV testing guidelines for head and neck carcinomas. The first guideline for HPV testing in head and neck carcinoma was published in 2018. Since then, a substantial body of research has emerged on HPV-related carcinomas. Given this growing evidence, it is essential that the guidelines are updated to reflect current scientific understanding. First, let's summarize major changes. HPV testing is now recommended for sinonasal squamous cell carcinoma. At this site, HPV-specific testing should be performed to accurately determine HPV status. While P16-IHC may still be used as an initial screening tool, a positive P16 result must be followed by a confirmatory HPV-specific to establish true HPV involvement. This is a major change from the 2018 guideline, which stated that HPV tests should not be performed for non-oropharyngeal squamous cell carcinoma. The second major change is the recommendation to perform HPV testing on all cases of metastatic squamous cell carcinoma involving cervical lymph nodes, regardless of nodal level. In these cases, HPV-specific testing is preferred over P16 immunohistochemistry alone. This update is at least partly related to the first change, as sinonasal carcinomas, which are now included in HPV testing recommendations, often metastasize to level 1 cervical lymph nodes. This represents a significant shift from the 2018 guideline, which recommended HPV testing only for metastases in level 2 and 3 lymph nodes. Having reviewed the key updates, we will now explore the revised guidelines more comprehensively. Guideline Statement 1 recommends that pathologists perform HPV testing on all cases of oropharyngeal squamous cell carcinoma. This is because HPV status is a critical prognostic factor in oropharyngeal SCC, with HPV-positive tumors demonstrating better treatment response and improved overall survival. This recommendation remains unchanged from the 2018 guideline. Recommendation 2 states that P16-IHC should be used as a surrogate marker for HPV testing in cases of oropharyngeal squamous cell carcinoma. In this context, a separate HPV-specific test is generally not required, as P16-IHC alone is both highly sensitive and specific. However, there are several scenarios in which HPV-specific testing should be performed to confirm HPV status. Geographic regions with low prevalence of high-risk HPV, such as parts of Latin America, Africa, and Asia. In these areas, P16 positivity may not reliably indicate HPV-driven disease. Equivocal P16 IHC results, where staining is ambiguous, neither clearly positive nor negative. Discordance between P16 staining and tumor morphology, such as morphology consistent with HPV-associated carcinoma, for example, basaloid features, but P16 is negative. Morphology not typical for HPV-driven carcinoma, for example, keratinizing features, but P16 is positive. Uncertain primary site, where the tumor is not definitively of oropharyngeal lymphoepithelial origin. Clinical trial requirements, when a definitive HPV status must be confirmed for eligibility or stratification. In all these cases, HPV-specific testing, such as HPV RNA in situ hybridization or PCR, is necessary for accurate classification and management. Guideline Statement 3 defines P16 IHC positivity as diffuse, moderate to strong nuclear and cytoplasmic staining in at least 70% of tumor cells. Equivocal P16 staining is defined as moderate to strong nuclear and cytoplasmic staining present in approximately 50% to 70% of tumor cells. Recommendation 4 reflects one of the major changes discussed earlier. HPV testing is now recommended for sinonasal squamous cell carcinoma. This change is supported by growing evidence that, similar to oropharyngeal squamous cell carcinoma, HPV-positive sinonasal squamous cell carcinomas are associated with improved clinical outcomes. Additionally, the incidence of HPV-associated sinonasal squamous cell carcinoma has been steadily increasing, further supporting the need for routine HPV testing in this setting. Recommendation 5 states that for sinonasal squamous cell carcinoma, HPV-specific testing is required, as P16 immunohistochemistry alone is not sufficient to determine HPV status in this setting. Recommendation 6 states that HPV testing should be performed in all cases of metastatic squamous cell carcinoma of unknown primary involving any cervical lymph node level. This is based on the fact that HPV-associated oropharyngeal squamous cell carcinoma is frequently present as metastatic disease, often with a small or clinically occult primary tumor. Recommendation 7 states that for metastatic squamous cell carcinoma involving cervical lymph nodes, HPV-specific testing should be used to confirm HPV status, rather than relying on P16 IHC alone. This is because non-oropharyngeal squamous cell carcinomas can also metastasize to cervical lymph nodes, and outside the oropharyngeal region, P16 IHC lacks specificity, meaning P16 positivity does not reliably indicate true HPV-driven disease. Recommendation 8 states that HPV testing should not be performed for squamous cell carcinomas of the oral cavity, larynx, nasopharynx, or hypopharynx. This is because HPV status in these anatomic sites has no established clinical significance. Even if the tumor is HPV-associated, it does not correlate with improved prognosis or treatment response. Recommendation 9 states that HPV testing should not be routinely performed in patients with non-squamous cell carcinomas of the head and neck, as HPV status generally does not correlate with prognosis in these tumor types. However, there are several notable exceptions where HPV testing may be clinically useful. These include neuroendocrine carcinoma, adenocarcinoma of unknown primary site, poorly differentiated malignant neoplasms that cannot be otherwise classified, HPV-related multiphenotypic sinonasal carcinoma. In these specific cases, HPV status may provide helpful diagnostic or prognostic information. Recommendation 10 states that HPV testing should be performed on cytologic specimens from metastatic squamous cell carcinoma involving cervical lymph nodes. Importantly, HPV-specific testing is recommended over P16 IHC in this setting. This recommendation is based on evidence showing that P16 IHC is less reliable on cytologic material compared to tissue biopsies. The performance of P16 IHC is compromised in cytology specimens, with reduced accuracy and diagnostic value. In contrast, HPV-specific tests, such as HPV RNA in situ hybridization or PCR, are more accurate and effective for determining HPV status in cytologic samples. Guideline Recommendation 12 states that HPV-specific tests include HPV RNA ISH and DNA PCR. While DNA ISH is not recommended, Recommendation 13 states that pathologists should not routinely perform low-risk HPV testing in patients with head and neck carcinomas, as detection of low-risk HPV types has no established prognostic or therapeutic value in this context. Recommendations 14 and 15 state that HPV testing should not be repeated in cases of recurrent or metastatic disease if the HPV status of the primary tumor is already known. However, if there is uncertainty about whether the tumor represents a new primary, HPV testing may be appropriate. In such cases, HPV-specific testing, rather than P16 alone, should be used to accurately determine HPV status. Guideline Statement 16 recommends that pathologists should not assign a tumor grade or differentiation status to HPV-positive oropharyngeal squamous cell carcinoma. As previously noted, these tumors typically exhibit basaloid features and appear morphologically high-grade. However, despite their appearance, HPV-positive tumors are associated with a significantly better prognosis. As a result, grading or assigning a differentiation status may be misleading and is therefore discouraged. CAP also outlined the guideline development process, emphasizing a rigorous, evidence-based approach informed by the latest research and expert consensus. This reflects CAP's ongoing commitment to continuously improving clinical practice in response to emerging data and evolving standards of care. These updated guidelines are invaluable not only to pathologists, who rely on them for accurate diagnosis and testing protocols, but also to the broader clinical care team, supporting more informed decision-making and optimized treatment planning. Ultimately, the greatest beneficiaries are the patients, who receive more precise diagnoses, appropriate therapeutic strategies, and improved outcomes as a result of these advancements.